Welcome to 502 Conversations. I'm Brian Kirby, and my guest, once again, is Dr. Christopher Labos. Dr. Labos, how are you doing today?
I'm doing very well, Brian. How are you?
I'm well. Let me give you a proper introduction, and then we shall begin our year in cardiology review. Dr. Labos is a cardiologist with a degree in epidemiology. He spends most of his time doing things for which he does not get paid, like research, teaching, podcasting, and speaking with me. Occasionally, he does find time to practice as a cardiologist so he can pay his rent, as well as save for an upcoming wedding. He realizes that half of his research findings will be disproved in 5 years, but he does not know which half. He writes for the Montreal Gazette, makes regular appearances on CBC radio and TV, and is co-host of the Body of Evidence podcast, where he and Jonathan Jarry take a skeptical eye at health claims and look at the body of evidence on a variety of health topics. He is also the author of the book, Does Coffee Cause Cancer? And 8 More Myths About the Food We Eat. The book is available to order right now, and it uses a narrative to explore 9 popular beliefs about food, such as chocolate's good for you, wine, and being overweight with a good dose of cholesterol are all healthy for you. And it doesn't really matter anyway because vitamin D cures everything, so why worry? I must say maybe those beliefs are a bit less popular now that the book has been out for over a year. Let's hope so.
Let's hope so.
All right, thanks for being here. A year in cardiology review. We'll talk about some studies and some writing that you have done. I do want to mention one thing right up front. So I must say I saw the photo you posted of the 1-year anniversary of publication of the book.
Yeah.
I couldn't help but notice, because this is what I do.
Yeah.
In the photo, there was a partially consumed glass of red wine
Yes.
and a cup of coffee. Now,
Yes.
am I to assume that the cake was also a chocolate cake?
Yes, it was actually. And here's a fun story from that. When my fiance commissioned the cake, she thought that'd be a nice little surprise for the 1-year anniversary. And so she found somebody who made it, and the person who made it ended up knowing me. She was a retired nurse from the hospital that remembered me as a resident. So when she went to pick it up, she looked at the name and she said, "Dr. Labos, I remember him." So it's a very small world sometimes.
Wow, she or he is now a baker?
Yeah. She was a nurse at the hospital. She's retired from nursing now, and she spends her time just making cakes that people sort of like custom order. And yeah,
I got to tell you, that cake looked fantastic. I
it
mean,
was a great cake.
It was
fantastic. It was such a good cake.
and they matched the book cover. I mean,
They-
I'll show a photo of it. It's
Yeah.
just unbelievable.
And it's hard to sometimes appreciate on the full photo, but because here, I'll have the actual book cover here. It's a cup of coffee, right? She had put a glaze on the black, so it looked like a shimmering cup of coffee, and she had ruffled the pages so that there was a serrated edge to the cake, like it wasn't flat here to mimic sort of the page. It was super, super well done. It was the amount of work that went into that cake was truly impressive, and it tasted fantastic.
Okay, well, there you go. I don't know. You want to mention the name of the bakery? So I'm sure people can find it. Your email is readily available.
There you go.
Speaking of that, have you gotten email or other responses to the book? I mean, from the public, not from professionals, but are people reading the book and saying, "Wow, thanks for opening my eyes," or
Yeah, people have. I mean, a lot of people have said, people in the media said, "No, I really liked it. It was really enjoyable." I was on Eric Topol's podcast, Ground Truths, a few months ago, and he was very, very complimentary. And he said, "I really liked the book. I think you've created a new genre of literature because I don't think many people use fiction to communicate science. I really do think that's a bit of an innovation on my part." So he really liked it, and then his podcast is just super popular. So just by being virtual on that, I got a bunch of sort of invitations from other people, and they all really seem to like the book. I think people like the book. There is a small section of the population that's like, "Oh, I would have preferred if you had just told me, just debunk the myths and spare the narrative," which is fine. I mean, it's a stylistic choice, right? You have to enjoy the idea of a narrative, but I think most people like that interplay. They enjoy the fact that it's not just a pure science book, that there are jokes, and people have said that they find it really funny. So, and you have to like romantic comedies. If that's not your thing, then you won't like the narrative style of this book, and there's not much that you can do about it. But I think people acknowledge that it's different and that it is sort of an innovative way of trying to communicate information to the public, because just a bland recitation of facts, I mean, that gets old quick, right? If I was just going to be up there and be like, oh, no, coffee doesn't cause cancer, people would be like, yeah, okay. But if you make it sort of funny and sort of draw people into the story, I think that makes it a little bit better.
One thing you just said, not many people use narrative to communicate science. I can flip that based
Yeah.
on some of the topics we're going to discuss. Sometimes people use science to communicate fiction.
Yeah, and if we get into the whole sort of pseudoscience versus medicine thing, I mean, one of the reasons why pseudoscience, peddlers are so successful is because they do have this very successful narrative, right? You can tell them, you can say like, oh, we have this study with 10,000 patients. They're like, yeah, but little Jimmy was sick and he took this supplement and now he can walk again. And, we might scoff at that and be like, well, it's obviously like not true, but it has an impact. And that's why the anti-vaccine rhetoric was so powerful, because it tapped into, fear and uncertainty, but it gave people a narrative, right? Oh, these vaccines are too new. We can't trust them, right? Normally, vaccine developments take longer. Now, none of that was actually true, and we can pick it apart, but that's the problem. If you don't match that narrative with an equally compelling narrative, for a lot of people, they're just going to listen to the better story. And so I think we have to start realizing that that's a thing in terms of how human beings actually process information.
All right, and we won't go deeper with the information deficit model and dialectical model and how those two interact. We will just leave that alone. Thank you for not mentioning.
That's a whole 1 hour show right there, and it's a fascinating topic, but it's not the topic for today.
Some topics from this year are what is on board for today, but I do hope I get to one that I really liked from 50 years ago, which falls into what you were saying about communicating science and how people get better anyway. All right, so first up, sodium versus potassium versus blood pressure. All right.
Yeah.
I want to lower my blood pressure. I want to use minimum effort. I want to get maximum benefit. So do I medicate, cut sodium, take potassium supplements, lose weight, exercise, eat a dozen bananas a day? What do I do?
Well, sort of all of those things.
Oh.
And here's the thing: the debate, and this was a Medscape article that I had written. A lot of your blood pressure is mediated via sodium intake. So for people who don't know, sodium chloride is table salt. Okay, so your table salt that you have in your kitchen is sodium chloride, chemically speaking. Our kidneys hold on to sodium, and that causes your blood pressure to go up. So for the vast majority of people, and when you look at it population-wide, the fact that we consume a lot of sodium in North America contributes to the high blood pressure that we deal with population-wide. Now, there's obviously other factors, there's genetic factors too, and as we get older, blood pressure does tend to go up. But if we could get people to consume less sodium, we would be better off. There was some controversy with the publication of the Pure study, and I do get into it in the book. There's a whole chapter on salt, so you can see where that controversy comes from. So there was some controversy with the Pure study about, oh, is sodium really that bad for you? I think when you look at the entirety of the scientific evidence, and you look at studies like INTERSALT, DASH, TOHP, which is trials of hypertension, trials of hypertension prevention, TOHAP, and then most recently the Cardia SSBP study. Those, I think, are pretty clear that if you reduce sodium from your diet, your BP goes down. And in fact, reducing sodium from your diet by a significant degree is roughly comparable with starting medication. So if you're somebody who wants to avoid medication, because you don't want to take medication if you don't have to, if you have a very, very high salt diet, then you can maybe not need blood pressure medication just by reducing the amount of sodium that you take in. And what's challenging here, and this is sort of the trick, most of the sodium that we eat is not the sodium, the salt that we are adding to our food. There's some of that, right? So the salt shaker on the kitchen table, that's problematic. The salt that you add during cooking is a problem. But most of the salt that we eat, most of the sodium that we eat, is added to our food by somebody else. So if you're eating pre-prepared food, processed food, or ultra-processed food, as some people use that term, that is where most of the sodium comes from. So a lot of the public health discussion and policy discussions that are happening are about removing salt from food and finding ways to substitute it with something else.
Yeah, that's the tricky part. I mean, if you really want to cut your sodium when you're shopping, you have to look at those labels, and it sneaks in it. And if you dine out, just forget it. I
Yeah.
can't imagine how much added salt there is because it's probably added at every step of the way for the salt.
Right, and that's the problem. Like, it's not a question of just telling people eat less salt, right? I mean, yes, obviously, don't add salt to your food if you can get away with it. Put pepper if you need that extra bit of spice or flavoring. A lot of it is added during food manufacturing, and that's going to require policy change. It's not something that you and I as a consumer can really do anything about. I mean, you can just not buy pre-processed foods, but people eat at restaurants, right? People go out, people buy stuff to leave in the freezer. So it's like, it's all well and good to tell people eat healthier. What's going to be really meaningful is, can we remove salt from the American diet or the North American diet, in the same way that we largely removed trans fats from the North American diet, right? Through a series of policy changes. I mean, that was an issue that was to a large degree addressed. So we just sort of have to do the same thing. And one of the most interesting things with salt is, can you substitute out sodium for potassium? So instead of having sodium chloride, can you have potassium chloride? And that's where you get a study like the SAS trial, which is not new. It's about 2 or 3 years old at this point. But that was, I think, one of the first trials that really demonstrated that you can have a profound effect, not by telling people get rid of salt, but can you replace it with something else that is not as bad for you? And the great advantage about potassium is that it doesn't increase your blood pressure in the same way that sodium does.
You've mentioned several studies. Was it SAS?
Mm-hmm.
I know there was DASH, which is dietary approach to, I don't know, these names that they come up with
Hypertension.
are great. Yeah. Maybe we'll talk about that. Like, it seems like, do they have to make it into an acronym? They always seem to trial, prevent, pure, surmount. Was it, okay, go ahead. Sorry.
For people who are interested, I wrote an article for Medscape several years ago about the evolution of medical acronyms. There was a time when the acronyms actually stood for something. So DASH really does mean dietary approaches to systolic hypertension. So it actually meant something, but more and more these acronyms don't have any relevance to the actual study title. So for anybody who's interested, just Google my name. It's on Medscape. It's about, the evolution of medical acronyms. And it's really funny how they have changed over time, and they are no longer strictly speaking acronyms. They're basically monikers that we use to, shorthands that we use for different studies.
Let's go to one of your other Medscape articles from this year. This may take a little bit more time. So cholesterol denialism is pseudoscience. This is in the book, but you actually have an article you have an article you also wrote that's in Medscape.
Yeah.
This is interesting to me because not long after there was a so-called rebuttal, which just brings up another point about communication. So yes. Cholesterol denialism is pseudoscience. So what is cholesterol denialism?
Cholesterol denialism is essentially the position that's been adopted by a very small minority of people. I mean, some of them cardiologists, unfortunately, that are trying to make the case that cholesterol has nothing to do with heart disease, that you can have high cholesterol and that your cardiac risk is not affected, and that we shouldn't be trying to lower it with medication or other means. And, if you take it at that basic level, if your argument is going to be that cholesterol has nothing to do with heart disease, then that is clearly untrue. And that requires, frankly, a denial of a huge amount of scientific literature. We can get into a very subtle argument about, who's the most high-risk people, how do we define and how do we refine cardiac risk, how do we decide who should be treated or who should be not. But if you take it at a fundamental pathophysiology level, does cholesterol contribute to heart disease? I mean, the answer has to be an unequivocal yes. To say anything else, you are really entering into the realm of pseudoscience. And if you look at the historical perspective, if you look at the whole history of cholesterol development from like the 1950s or even the early 1900s onwards, there were periods of time when there was like reasonable controversy and debate about whether this was worth it, were the medications good enough. Prior to the 1990s, a lot of the medications that we had for lowering cholesterol were just not that effective. So if you were if we were talking in the 1970s, 1980s, and we had said, should we be treating cholesterol? There was a valid debate to be had because the medications were not that good. They had a lot of side effects associated with them. There was some debate about whether it was worth it or not. But once you get into the post-statin era and with the newer medications that exist now, like PCSK9s and inclisiran, small interfering RNAs, all the stuff that's being developed in the field of cholesterol, I don't think you can make that argument anymore. And a lot of people are still holding on to old ideas that have been disproven. And that's why sort of the title is like cholesterol denialism became a pseudoscience, because it was really a consequence of people not being able to let go of past debates when the scientific evidence really evolved. And of course, the 1980s were not that long ago, right? A lot of the people having these arguments are still alive. So it's a question of, were you able to change your mind? And that is a very hard thing for people to do. So I think it was a very interesting scientific article to write, but it was also a very interesting human nature article to write, because it really explores why people sort of lock on to things that probably should have been abandoned as ideas long ago.
All right, let me sum this up. So no denying, well, I'm going to say there's no denying based on what I'm summing up what you just said. So there's no denying that lowering cholesterol reduces heart attacks, cardiovascular disease, all-cause mortality, whether you use a statin or if you can do it without medication. Lowering cholesterol lowers risk. And then in your article, you do point out there are still questions to be asked, right? Who benefits the most? What about cost? How do you do the risk scores, right? How should those be calculated? Because I think they came up with a new scoring system this year. I can't remember if it was USPSTF, but so the rebuttal. So I don't know how much later there was an article, a rebuttal, so to speak. And this is what's interesting to me. People should read both of these because I think this happens a lot. The rebuttal argued at points you didn't make.
Yeah.
Which I don't know if you read the rebuttal or not, but it was, when I read through, I'm like, well, wait a minute. So I'm just going to go through some of those because it's an interesting exercise. People should read it for that purpose. So these authors do admit that statins for secondary prevention, they're okay, but there's a lack for primary prevention, right? So that's what you're saying, who benefits the most, right?
Yeah.
And that they quote this NHANES study. Oh, well, there you go. National Health and Nutritional Examination Survey. Is that it?
That's pretty close. I never remember
like,
what that stands for.
Right. It's another one of those NHANES. Okay, so it says, I guess they quote this study saying that 2/3 of people that use statins that are not at high risk. So why bother, right? Or a United States Preventive, a USPSTF study that found 12 studies that none of them showed a statistically significant risk. And they quote a Cochrane review from 2011. So they caution, I guess, that people, when they're taking statins for primary prevention, you have to ask who is at low risk and who is at high risk. But that's a point you made, right? Who benefits and how to assign risk. So that's the first thing they did. They're arguing against a point they're agreeing with a point you made, but it's in their rebuttal.
Yeah.
But the biggest thing that they do is they sum up with two problems they have, and they say, here are the problems with his claim of statin denialism. That wasn't your argument.
No.
Your argument was cholesterol denialism.
Yeah.
So they're arguing right there. They just changed the argument. I failed to see how that wasn't noticed by the editors, by the way, and they didn't make them change that or come up. But anyway, so they change it to statin denialism. They bemoan that they don't have this study data, and then they agree with your secondary prevention. So
yeah, well, and this is the thing. I think more often than not, if you can actually get people and nail them down, you start to realize that a lot of these controversies are not as profound. When I wrote the article, just to backtrack a bit about sodium, right? It was very much written as a sodium debate between two physicians, Swapnil Hiramath here in Ottawa, Canada, and Stephen Juracek down in the US. But, one was arguing for sodium, one was arguing for potassium, like which is the biggest implicator. But the reality is they weren't disagreeing really all that much. And they are friends, colleagues, right? And so the idea of a debate is often more for entertainment value. Like they did this debate live at one of the nephrology or hypertension conferences, right? So there's not much antagonism there. And I think I end the article by explaining this isn't Twitter. There's actually a lot of points of agreement here, and a lot of it becomes a question of policy and what do you want to prioritize in terms of policy. When you get people to talk about cholesterol, if you actually sort of, they'll make a point, it's like, oh, I think we're overusing statins and, there's no benefits. You're like, okay, but it's not about statins. It's about lowering cholesterol. There's many other medications that we could use to lower cholesterol. It's just that they're a lot more expensive. The great irony of the whole debate about, people who object to statins is that statins are not the only cholesterol medication out there. They're just the cheapest and, the ones that tend to have the most effect. But I mean, there are better medications out there. It's just that they're injectable medications that are quite expensive. So if people object to statins for whatever reason, the proper argument should then be, okay, well then let's use something else to treat cholesterol and let's find ways to make these medications more affordable for the general population. So if you want to attack the cost-benefit ratio associated with statins, we can have that argument. But that's a different argument from saying cholesterol has nothing to do with heart disease. That's a completely different argument.
There's so much to talk about. Let's move on to another one of your articles, because this one probably sent waves of glee through people, and then you had to say, oh, no, probably not so much. So the topic was endurance exercise, and this made a lot of headlines. Yes. That marathon runners, they have more cardiovascular disease or more arteriosclerotic buildup, or is it ethereal? I'm not sure. There's probably a debate about that, right? So the question is endurance exercise harmful? So I read this article a couple of times, and then I read a couple of the studies. So running, cycling, competitive or not, they mean high-level athletes, marathons, cycling races, and that kind of thing. So what's the story here? What happened, and why is this a headline?
So there's a few things that have always made people a little bit worried about marathons, like the idea of sudden death. And, if you have a marathon in your local city, there's always a news report about somebody dying during the marathon or the ambulance is having to be called to take somebody to the hospital. However, the rates of that are pretty low. I mean, when you look at studies that have been done with the Marine Corps, the Twin Cities marathons in the U.S., the rate of sudden death during these marathons is 0.002%. So it's extremely low. There's a few reasons why sudden death can happen. It's often tied to high heat, dehydration, stuff like that. Or the person may have had some pre-existing cardiac abnormality that was either undiagnosed or wasn't properly appreciated. So there's reasons for it. But what's happened in the past few years is that there's been more studies looking at coronary calcification. So meaning, do you have calcium in your arteries? Do you have atherosclerotic plaque in your arteries? And so one of the big studies to come out was the Masters at Heart study, which really did show that endurance athletes had more plaque and significantly more potentially unstable plaque. Because prior to that, the argument or the narrative can be that, you were seeing more calcium, but calcifying your plaque is actually a good thing, because what causes sudden death, what kills you, what gives you a heart attack, is unstable plaque. So if exercise is leading to more calcification, that's actually stabilizing the plaque you have and probably being protective. But then the Masters of Heart study came out and it said, there's actually more unstable plaque as well. And so that led to the possibility of saying, maybe endurance exercise is bad for you. Maybe you can have too much of a good thing. And of course, you can go back to the very, very beginning of the marathon, because the first person to actually try to run a marathon was Philippides of Athens. And he died at the end of it, right? He got to Athens, he screamed out Nike, which means, victory in Greek, to tell the Athenians that they had beaten the Persians at the Battle of Marathon, and then he dropped dead, according to legend. That may or may not be a historically true story, but at least according to legend, that's where it goes. So there's always been this concern that endurance exercises may be too much, and so these studies about calcifications have been adding to that and sort of giving people a potential mechanism for why it might potentially be dangerous.
Let me also ask you a question, because you have this degree in epidemiology. So you may have to talk a little bit about the difference between an observational study and a controlled study, because I think this Portugal study from 2024, the Masters at Heart study, they were observational studies. So they kind of went looking for this. Is that, you want to talk just briefly about that? Hit people?
Well, and so this is the thing, like a lot of the way these studies were done, they were sort of cross-sectional studies, right? You get people who do these types of endurance exercises, you do CT scans of their heart, and you look at the amount of coronary calcification, which is, it's fine for what it is. But what you really care about is progression over time, right? Does doing exercise speed up atherosclerosis? That would be bad. Or does it sort of stabilize it? because fundamentally there are going to be differences between the people who do endurance exercises and don't, right? I mean, it could be that you hit your 50s, you find out you have high blood pressure, cholesterol, diabetes, all of a sudden you start running regularly and that changes your habit. So what you would ideally want is a randomized controlled trial, which for all practical purposes would be inherently impossible to do. Like, you can't force people to exercise, right? But you at the very least want something that's prospective and that has multiple time points, where you would do regular CT scans every 6 months, every year, for example, to see how things evolve. But that would be very costly and very, very difficult to pull off. So we don't have the quality of the data that we would want to be absolutely definitive, because there's a lot of unanswered questions. Like, how does this relate? Like, are certain types of exercise worse than other types of exercise? Is there a difference between men and women? Like, most of the data has been in men, and when you look at subgroup analyses in women, you don't see the same effect. So does that mean that men and women are different, or does that mean that women have just been underrepresented in the studies that have been done so far? So there's still a little bit of uncertainty. Sort of the one study that was actually prospective did not suggest that there was more plaque progression. And when you look at people who do endurance events like the Tour de France, that was one study that came out. They looked at the Tour de France people versus the general population. The people who did the Tour de France had a lower risk of death overall. So yeah, maybe you're seeing more atherosclerosis, maybe you're not, it's hard to say. But when it comes to hard outcomes, I'm like, am I more likely to die if I exercise? I think the answer is no. You're less likely to die relative to the general population that is unfortunately increasingly sedentary, at least in North America.
And I'm not quite at the end of this yet, but let's just say right now, though, there's no doubt that regular physical activity is protective, even in patients with coronary artery disease, right? It's good for everybody, and even those that are already sick, and inactivity is going to increase your risk. All right, so that's in there too, right?
Yes, exactly. And I think that's the point, that for most people, we don't move enough. Most people do not get enough exercise. They do not get enough physical activity. And what most people need to do is move more, not less. You don't have to run a marathon and be healthy. In fact, you start to extract cardiovascular benefits from exercise if you go for a 30-minute walk every day. And, that is doable. That is something that most people can pull off. You just have to do it.
And in the Masters at Heart study, because the original study points, of course, to other studies that have been done, they did say, right, contrary to prior expectations, this is what they found, that endurance athletes had a higher prevalence of the plaque, but this calcified plaque, but they weren't really experiencing symptoms, right? And then they even gave us the reverse J-shaped dose response, which I found interesting. So because I had to think, well, wait a minute, that means what's a reverse J on TV? Is that like high exercise bad, and then lower it's better, and then if you do none, it goes up again? But these people were not symptomatic. I mean, they just found this because they were doing this testing.
Right, exactly. And so that's part of the thing, too, is that you always want to look at hard endpoints, but that's a hard thing to do. And so you have to, again, it would be very easy for me to be like, this is all garbage. There's no hard clinical endpoints. I'm like, right, but let's acknowledge that's going to be a very hard study to do. Like, you would have to follow people for decades. Because it takes a while for people to develop heart disease. If you're taking young, healthy people, mostly men, right, that's another limitation, but you're taking young, healthy men in their 30s and 40s that are, I don't know what the average age of people in the Tour de France is, but they're on the younger side, right? You're going to follow them for the next 20, 30, 40 years to find out if they have heart attacks. You're going to keep sending them questionnaires and having them come in for follow-up. Like, let's acknowledge that logistically that's going to be very complicated. You can do it using administrative data, but there are limitations to that. So we live in an imperfect world. Sometimes you have to make the best decision with the information you have and realize you can't always have a randomized controlled trial for every conceivable situation. I mean, that's an easy thing to say. It's impossible to actually do.
All right, my final thoughts on this study. This was the most bizarre thing I think I've ever read. Well, maybe not, but right up there. In this Portugal study, when you get to the demographics and the patient characteristics, 8 of the 105 that they studied were smokers. What? That made no sense to me. So 105 endurance athletes, 8 of them were smokers. What? So like, okay, just let me finish this cigarette and then we can start the marathon. What is that all about? Did you read that?
Well, here's the thing. We sometimes forget. In Europe, the prevalence of smoking is a little bit higher than it is in North America. There are still people who smoke. It's
marathon runners. It makes no sense.
Listen, people are people are funny creatures. Like, people have a lot of bad habits, you know? I mean, running a marathon, although we have this conception that you would be this like paragon of human health, it's not necessarily so. These are human beings with their own flaws and foibles and bad habits. And, sometimes people who are very, very active still have bad habits. And let's acknowledge that smoking is hard to quit, right? I mean, tobacco is an addictive substance. So somebody who started smoking when they were a teenager because of, societal pressure and whatever, they may want to quit and they can't. And that's a reality that a lot of people live with.
I guess they didn't, or if I didn't see that, they did not specify what current smoker actually meant. Like maybe they have a cigarette after the marathon or something. I don't know. Maybe it's not. When I think smoking, I think smoking.
Yeah. Well, usually, and it depends on the study, but usually in the studies, they say, have you smoked a cigarette in the past year? That is how many I don't remember what they used particular in that one. I genuinely don't remember. But it's usually that, because that's what life insurance companies use to predict your future risk. And that actually has some data behind it. Like, have you smoked anything in the past year?
All right. More about potassium after cardiac surgery. This was an article in Medscape, I think. So this also had a great opening sentence, which I won't read in full, but it's, potassium supplementation, it doesn't alter the risk after for atrial fibrillation post-op. Anyway, but it said the part I loved was contrary to expectations and popular clinical practice. Yeah. This new trial says it's not true. I'll get back to why I love that sentence later. But anyway, what was this all about?
So atrial fibrillation is an arrhythmia, very common arrhythmia. We often see it after cardiac surgery. Like, the risk of going into Afib after cardiac surgery is actually quite high. It's a known problem that has to be dealt with in a hospital. And one of the things that people do in hospitals, you try to replace potassium, because low potassium has been shown in some situations to create an arrhythmogenic environment. So if your potassium is low, if your electrolytes are out of whack, it's felt that increases your risk of atrial fibrillation. So if you had cardiac surgery and you're in the hospital ward and you're recovering and they do your daily blood test and they see that your potassium is low, you would often get a potassium supplement to try to get your potassium back up. And this is routinely done. And I can tell you that as a resident, we spent many an hour checking and replacing low potassium, thinking that it would make a difference. And I think what was fascinating about this study is that they actually did a randomized controlled trial to establish if that actually made a difference. And it didn't, right? And you might say, it's like, well, like, who cares? It's a potassium supplement. It does no harm. And that's true. But you have to think of it in terms of the amount of money and time that was wasted in the checking and replacing of potassium. And so if we get rid of this practice, that would actually be a huge cost savings, not so much in terms of the cost of potassium supplements, which are, of course, very, very cheap, but in the terms of, human efficiency. Like, we won't have to waste human labor doing something that has no impact. So this was a pretty important trial. Even though it sounds like it should be like a trivial thing, it's an important trial because it really will change practice and make things just a little bit more streamlined in your post-cardiac surgery care.
And the reason that sentence jumped out at me, contrary to popular expectations in clinical practice, was it reminded me of this study I had read, which I don't know if you've ever seen it in your course, but it was from the 1959 or 1960. This internal memory artery ligation for angina or angina. There's another word, whichever way you go. It was common to do this artery ligation for angina all the way up until the 50s and probably beyond, until someone actually tested it. And it turned out that in a double-blind test, and it was really well blinded. I mean, the surgeons were handed an envelope after anesthesia. The people doing follow-up didn't know who got which one because they did incisions on both patients. And it turned out that the placebo group actually did better. Yeah. Because there are complications from the surgery. And I mean, we're also talking objectively better. I don't know if you ever saw that study or not, but it just brought me back to that. Like, when you really test something that's popular and everybody does it because they think it works, and then oops.
Yeah, and it underscores a real problem with surgical research is that, there's not many situations in which you can do a sham surgery, right? Because if you compare surgery to medical therapy, well, that's often going to be unblinded. People know if they got surgery or not, right? So one of the things that you want to do anytime you're developing a clinical trial is you want it to be randomized, but you also want it to be blinded. You don't want people to know whether you got treatment A or treatment B. And for surgery, that's really tough because people know if they had surgery. And so to do a sham surgery where they brought people into the operating room, did an incision, didn't actually operate, but then closed them up. So the patients thought they had surgery because they were left with a surgical scar. That was pretty impressive. And this is one of the historically important trials in cardiology because as a result of it, we did stop doing internal mammary ligation. It is, I think, an example that you can do sham surgeries in clinical trials, even though it's technically very challenging to do so. And it's an important trial because a lot of things can make sense clinically, and yet when you actually try them, they don't seem to work. And there was a very similar phenomenon with renal denervation, which was this interventional procedure to treat hypertension. They had a bunch of preliminary studies suggesting there was a huge benefit, and then they did a sham control where they put the catheter into the renal artery, but they didn't actually ablate anything. They just took the catheter back out again, so the patient didn't know if there was whether the procedure was done. And that final trial, it was part of the Simplicity Hypertension program. I don't remember if it was Simplicity Hypertension 3 or 4. It's a while now. It didn't actually show a benefit. So people do still use renal denervation, maybe in some situations, but it just goes to show you how important the placebo response can be and why you need to control for it and why it's sometimes very, very difficult because sham surgeries, that's a big ask to do when you're developing a clinical trial. Like let's appreciate how complicated and difficult that would actually be.
If anybody reads that study, the internal artery ligation one, when I say the placebo group did better, I mean it. I mean, one or two of the people were, they had stopped working because the pain was so bad from the angina, and basically they were sitting in chairs all day long. And objectively, there were objective measurements. But then the person that had to stop working, I mean, he came out of it and started working again. And objectively, he had better measurements, but he was in the placebo group. It was just astounding. Doubling death rates due to intermittent fasting, another big headline. So a couple of questionnaires, another one of these observational studies, I assume, because it was questionnaire-based. So what's up with doubling death rates due to intermittent fasting?
I mean, it was shocking how this took off. What this actually was is this was one of the medical conferences. I actually can't remember which one now. But basically, what happens at medical conferences, people come, they present their research. Most of it is what it is. And I can't remember if it was the AHA or the ACC, but anyways, one of them put out a press release, as they do, saying, oh, look at this very interesting study that showed us, doubling of death rates with intermittent fasting. And, people ran with it because if you put out a press release, journalists will see it. They will write a story based on the press release, right? And maybe they'll do a few interviews with the main author. And so this really took off. And what was fascinating about it is that we didn't actually have the data. I mean, let alone that mostly what people present at a medical conference is what's called an abstract. So it's basically like a short summary. It's basically like a one-paragraph summary of the research. So not only did we not have a full published paper to analyze, we didn't even have an abstract because everybody had based it just on a press release. And when they ultimately put the poster presentation online for people to see, it was like, yes, you had that one finding where there was an increased risk of cardiac death, but then there were so many other analyses there. And I thought that was a perfect example of multiple hypothesis testing, where if you do 20 analyses, just by random chance, one of them will turn out statistically significant, right? So they had tested like various different types. I think there were multiple outcomes. They were looking at heart disease, but also cancer outcomes. And it was like sort of negative across the board, except for that one analysis that showed a purported doubling of the risk. And it was like, well, no, right? Because if you actually publish this in a paper, the peer review would probably, one would hope, force you to sort of adjust your findings to say that this was a mostly negative study with one outlier that would have to be replicated by a different group before it was taken seriously. And here's the thing, it's not wrong, and this was, I think, a student presentation or a resident, it's not wrong for students and residents to cut their teeth on smaller, more preliminary fields of research, right? There's nothing inherently wrong with that. But we need to be better at separating out hypothesis generating research from stuff that's actually definitive. And I think there was an appropriate amount of criticism to be leveled against the conference association for putting out a press release on this, because this was not a newsworthy study. I don't begrudge the person who did the research, but you shouldn't be publicizing this to the press. So yes, the journalists shouldn't have run with it, but they also should not have put out a press release for it, because this was this was non-definitive research. Let's be charitable and call it that. And it's not something that should have remained a significant issue.
In their defense, it was called a press release, right? So to say the press ran with it, I mean, it was a press release. What do they?
I think the question becomes, do you have a responsibility to not promote something that isn't definitive? Because the argument from the conference organizers was, well, I mean, we just put it out there. It's the journalists who have to decide whether they want to publish the story or not. And the journalists
I don't think that's not fair.
That's the thing, right? The journalists are like, well, listen, you're telling us this is the thing. I mean, we're going to report what you say, It's like, when you get this type of finger pointing, I'm not sure that's helpful. I mean, in the same, look, all research has value to differing degrees, right? And that's why I say, I don't think the argument that some people had is like, oh, this should have never been presented at a conference. No, conferences are for sharing information, but not everything is equally valid. I think the minute you highlight something with a press release, you're implying something to the general public. And I think there needs to be a little bit more introspection from people who produce research to realize it's not enough to just be like, well, here's my study and then wash your hands and walk away. There is a responsibility to be a little bit more judicious in how you communicate it to the public and acknowledge the uncertainties of your own research, because sometimes you have researchers who think that everything they've done is Nobel Prize worthy scientific research. And no, acknowledge that it is preliminary, that it probably might not be untrue. It's interesting for what you did, but 6 months down the line, somebody may come out and show something completely different. That has to become part of the conversation. It's irresponsible to yell fire in a crowded theater, even if there really is a fire going on. So we have to be a little bit more mindful of the implications of our words, because even if you accept that the findings were true as far as they went in terms of an observational study, telling people that intermittent fasting doubles the risk of death, that's going to be misunderstood by the majority of the population, when in reality this had very little in terms of clinical impact for most people.
And what you said there was super important, the subgrouping upon subgrouping.
Yeah.
That comes up a lot in a lot of these shows that I do, because it comes up a lot with brain supplements, right? 29 subgroups. Oh, here's one that hit. I don't think Cosmos was totally like that, but they did write 5 papers on one thing, and they did, can you call in? Can you go on the web and come in? Can you actually drive in? Yeah. So maybe we'll talk about that later. But anyway, that's another one of those sort. Maybe.
I actually do have a Medscape article on this, so if anybody was interested, you can go find the stuff on Medscape.
All right, let's move on. Chelation therapy for heart disease. Now, right away, when I say chelation therapy, that's going to raise the ire for a lot of people on both sides of the aisle, because chelation therapy, it's one of those favorites from alternative medical practitioners for a variety of conditions. So you probably heard of this for, I don't know. I don't even know what they use it for, but a lot of different stuff. But anyway, so what's up with chelation therapy for cardiovascular disease, and how is it defined, and what is it used for in medical practice? Real medical practice.
Yeah, so it shouldn't be used in medical practice unless you actually have heavy metal poisoning, which can in theory happen, right? But there is no role for chelation therapy in cardiovascular disease. This became an issue because of the publication of the TACT trial about 10 years ago, actually 11 years ago now maybe. The TACT trial was published suggesting that there might have been a benefit for chelation therapy. It had a number of problems with it. It probably wasn't blinded. It was being run in clinics that would give chelation therapy to patients, so a lot of essentially alternative medicine clinics. And the fact that you would do this in outpatient private clinics rather than in a hospital setting was strange. There were a number of other problems. There was a very high dropout rate, suggesting that patients themselves knew whether they were getting chelation therapy or not, so they were not blinded. So the original TACT trial had a lot of problems with it. There was a follow-up done called TACT 2, which got published this year, essentially showing that there was no benefit to this, because the original TACT 1 was sort of equivocal, but maybe there was a benefit in diabetic patients, so they redid the study in diabetic patients and they showed no benefit whatsoever. And then you had people trying to explain away why, and they were like, oh, maybe there's less heavy metal poisoning than there once was, which I don't think much has changed in the past 10 years in terms of, mercury poisonings or lead poisonings and whatnot. So this was another important trial, a very expensive trial, let's be honest. I mean, a lot of money. I mean, this was literally the definition of throwing good money after bad. And yet it had to be done, because otherwise people who practice or who sell this procedure to patients would say, oh, look, we have this positive trial that, we're doing evidence-based medicine, when in fact, no. So there's really no role for chelation therapy in the treatment of cardiovascular disease, no role for chelation therapy in treating like autism or many of the other things that it's often marketed for. If you do get heavy metal poisoning, then yes, you have to remove those heavy metals from your body, but most people are not going to experience heavy metal poisoning, and heavy metals are not responsible for all the multitude of health problems that they are often claimed to be associated with, right? There are usually other underlying reasons as well. But again, heavy metal poisoning, because it ties into this fear that a lot of people have, that a lot of our health is now outside of our control. Like, we are no longer in control of our food supply because our food is being made and manufactured and sold to us by somebody else. We no longer have control over our environment. Big polluters are polluting the environment and we can't actually stop them. This fear and this anxiety is contributing to this sort of thing. And I think that's what chelation therapy really taps into, when the reality is that no, it does nothing. And yes, there's certainly a lot that we can do about improving the quality of our environment, right? We should be working towards a cleaner environment, cleaner air, cleaner water, not polluting our lakes and our rivers. Absolutely, 100% that's true. But the solution to that is clean up the environment. The solution to that is not give people an unproven medical treatment that does nothing.
All right, you've just mentioned 3 topics that we could spend an additional 3 hours on. Searching for a positive trial.
Yeah.
Claiming that you practice evidence-based medicine, and what does evidence-based mean?
Yeah.
And then lack of control, being concerned about things that you don't have control over, as opposed to taking control over what you do have control over. I think this came up for me in that fluoride study, lowers IQ. Yeah. They didn't define IQ really that well, and it was other countries, and the dose was more than double what you actually get in your fluoridated water. Yeah. But it became, it's a big deal. Oh my gosh, it's because you don't have any real control over it unless you lobby your government to change it. But meanwhile, if you're going to run a marathon, don't smoke, right? Don't drink, don't do this, don't do that. So, okay, so totally 3 different topics there that you could go on. So in your next book, you might want to hit some of those, evidence-based medicine. So do a chapter or a book on acupuncture and all these evidence-based trials they do, that if you really look at them, I would question those.
There's always questions about, was the control group really blinded or not? And it just goes to show you, running a clinical trial is hard. It's not easy, and doing it right requires a lot of work, and very minor deviations from study protocol can have a huge impact. And there's a reason why research is hard. It requires very, very meticulous attention to detail, and sometimes a lot of trials just don't hold up under scrutiny.
Yes, but now your acupuncturist can point to 4 or 5 studies that were published in JAMA last year that claim positive results. And my beef is, what are they thinking at JAMA? Because when you start to read the study, in the introduction, you can find a flaw or 2. Yeah. And so you don't have to go on. Again, topic for another day. Add a chapter about artificial sweeteners, too. There's another one. I don't know if you're even writing another book. But anyway,
I actually am. I'm writing a potential sequel. And the sample chapter that I've already written, actually, is about artificial sweeteners, which I think is a really fascinating situation in terms of, why people think they are dangerous. When you look back at how they were first approved and the conversation that's happening now, a lot of people think that it's a continuous conversation. And no, there was this, anyways, I won't spoil it, but it's like there was this huge initial concern and then quiescence for a little bit, quiet, and then all of a sudden, oh, now people are concerned for a completely different, unrelated reason. So it's really fascinating to see how that discussion evolved as well.
All right. I look forward to reading that. And maybe you can write a whole book, make it like encyclopedias. So do the A's cause cancer or whatever? You know, all A studies, 9 chapters on A's.
Yeah.
So, all right, Dr. Christopher Labos, cardiologist with a degree in epidemiology. Follow him on Facebook as you are continuing to do many live events, right? You're doing book signings and author talks. The book is Does Coffee Cause Cancer? You can also find Dr. Labos on the Body of Evidence podcast, an excellent podcast, I must say. So I don't know if there's anything you'd like to sum up with here, your favorite study or worst study of the year, or...
I mean, my favorite study of the year was really the potassium after cardiac surgery study, which showed that there was no benefit to replacing potassium after cardiac surgery because we would just spend so much time doing it as residents that it was just such a waste of time and resources. So I think that was great. I mean, the worst of the year was maybe the intermittent fasting one, because this real concern, like it really became a media phenomenon that didn't need to happen just because of one very maybe poorly worded press release, or maybe a press release that shouldn't have been put out to begin with.
Okay, I guess my favorite worst study was the fluoride one.
Yeah.
And then, but also it's a toss-up between that and Cosmos. And look up Dr. Labos' writing on the Cosmos study because Cosmos was cocoa extract or multivitamin and cognitive decline, right?
So
and
there
cocoa
were 2
extract.
parts to it. Yeah.
Go ahead.
There were 2 parts to it, actually.
Oh, there were
it was
5, 7 parts. I don't even know.
Yeah, there was a cardiovascular endpoint.
Oh, right.
There was a neurocognitive endpoint, and then there were like multiple sort of like based on which follow-up. There was like Cosmos Mind, Cosmos Web, Cosmos. There was a
clinic,
few,
Cosmos Clinic.
Yeah, you know, it's all about like you're doing a different study based on the type of follow-up. That doesn't really make sense. Like there was a time when these would have all been one patient group. But anyway, so it was interesting to see how they really had to slice up that salami to get one positive result. And nobody talks about how the chocolate stuff was negative. Everybody still says, "Oh, chocolate is good for you." It's like, no, we actually proved this, I think, very definitively in the Cosmos study that chocolate does absolutely nothing, and yet that's not the thing that gets press. Everybody wants to talk about the multivitamins.
It's not even chocolate; it's cocoa extract.
Cocoa extract, yeah.
Which you'd be making a big leap from cocoa extract to I'm going to have a Mars bar and improve my cardiovascular health. But that's where it goes, of course. And I think the interesting thing to me is I read your article on it, and then they also linked one of the authors from a year ago video with this beaming face about how groundbreaking this study is and all this great evidence. And never mind that cocoa extract is not chocolate. Wasn't this the one also where they subgrouped and it was something like the cognitive improvement was the placebo group, they could recall 8 words, and the intervention group could recall 8.3 words out of 20.
Yeah, it was a very modest benefit, on some neurocognitive tests, but not others. And it's like, that's not what people care about. What people care about is, can I live at home for longer and not get dementia? Like, you know, do I avoid having to be put in a nursing home? And that's not what they do, because again, that would be a very hard study to do. So they're giving people these tests, and neurocognitive tests, they are, good as far as they are, but that's not the same thing as preventing dementia and allowing people to live independently. That's a very different thing.
All right, Dr. Christopher Labos, I thank you so much for being here. I guess we bounced all around, so I apologize for that. And I apologize, we did have some technical difficulties. Sorry about that, but I think this went well.